Okay, so that leads us right into discussion now that I'm reading the agenda. So are there some questions out there? I think Valerie's collecting some as well. Yes.
So, I'm Lisa Pearson. I'm on the Benton Local Advisory Council, the IHN Community Advisory Council. I'm also the chair of the Benton County Health Department's Mental Health, Addictions, and Developmental Disabilities Advisory Council. One problem across the board.
Can you hold the mic up closer?
Sorry. One problem across the board that we have, that's scary, is that we lack providers, especially in the mental health arena. And we have a lot of psychologists and therapists, not enough, obviously. We are critically short on psychiatrists. I know of several psychiatrists in the area who've been trying to get enrolled with as OHP and IHN providers. There seems to be a real problem with the reimbursement rates, not so much with therapists, but with doctors who are actually psychiatrists. Does IHN have any plans, or have you looked into the comparative reimbursement rates for psychiatrists in the area?
So thank you for bringing that up, and I think we've talked about this before, but we definitely do look at that and do our best to figure out how we fit in the whole spectrum of Medicaid and Medicare and commercial plans. And I think if there's a specific issue, would you please have them contact me directly, and we can figure out if there's a disconnect or if we're missing something, because historically and from what we've seen, we're in the market for a Medicaid psychiatrist payment. So I need to talk to that person and see if there's another piece that I'm not aware of. So I'd be happy to do that if you want to have them contact me directly. Okay.
Have the Medicaid reimbursement rates for physicians actually in the mental health arena compared to private reimbursement?
They're much lower. So the state funds the Medicaid plans at a different level than traditional commercial insurance plans are, so that the reimbursement tends to be lower as well. And it's across the board. It's certainly not just for mental health. Yeah, good question. Yes. I think the mic is coming.
So I heard a doctor speak the other day, and they brought up a good point, and that was, how many times do doctors look at a prescription list that a patient's on and say, maybe it's time we reduce this prescription medication, or maybe it's time we eliminate this medication and
give this to the doctor.
Okay. Is there a push to do more of that?
So in the concept of the primary care medical home, absolutely. And, from when I started practice 20 plus years ago, 25 years ago, to today, the amount of prescriptions that are available to us has quadrupled. It's huge. Direct-to-consumer marketing has made an impact. You can't watch the nightly news without seeing 6 to 8 commercials on all these different things that you should now be talking to your doctor about. So polypharmacy is a legitimate issue, and as we age, polypharmacy becomes a bigger and bigger issue in our body. We can't clear the medications like we normally can. Our kidney function decreases, our liver function decreases, and we build up more toxic metabolites. So in the concept of the primary care medical home, many clinics, and Samaritan has several, are employing pharmacists in the medical home concept. And this is a really, really good strategy, because today, pharmacists are actually some of the most knowledgeable when it comes to medication interactions and medication side effects. It's become more and more difficult for physicians to keep up with all of that plethora of work. And so how we successfully utilize those pharmacists in clinical settings to be part of the whole care team and to do the evaluation of the medication list when they're in the outpatient setting, when they're admitted to the hospital, and how that communication flow of changes or reductions to medications is really going to be key. I always say start low and go slow when it comes to medications. But again, that's where we use our other resources that are more skilled at doing that, and I highly recommend pharmacists as being part of the primary care team.
So second part to my question, medical marijuana. Are you talking about that, or are you kind of waiting to see how things roll out, or how is that fitting into?
So
some of
that's
these
such a loaded
strategies?
question. Yeah. Um, Marijuana is now legal in our state recreationally, and it's been used from a medical perspective over the last few years. If I ever had to go back in time, one of my wish lists would have been to not medicalize it in the first place, because I think it trapped us. Now, can marijuana help in some conditions? I think so. But I think that we got caught in the effort to medicalize it without any of the supporting evidence and research and data help guide physicians. So now many physicians are being caught in a situation where their patients may be on marijuana, and they may also be taking opioids. And together, that may be a dangerous combination in terms of breathing and that respiratory effort to keep breathing. So now we're feeling stuck. And the message that the community might get from many physicians, and I completely understand it and get it, is we might need you to pick one or the other because I'm really not sure of the combination of both together of what it's going to do. So my preference would be not to medicalize it, but if it's going to be a legal drug to use in Oregon at least, then so be it. Now there's another thing. Practicing physicians have something called a DEA license. And we get the DEA license from the federal government. So while Oregon as a state has decriminalized marijuana, federally, it's still against the law. So as a practicing physician, again, I sometimes feel I'm compromised a little bit because my DEA license could potentially be on the line if I'm willing to not look at my patients that are using marijuana and try to have a conversation with them. So we're a little stuck right now.
Other questions?
Hello, this is Mark. Hello. uh, I have been to this Benton community for many years, and my primary doctor is at Kovanis Clinic for many years. I found many doctors and the staff are very nice, are very good, but I still find a few of them are lacking of experience and need more training and development. And some equipment in the local are not so advanced. For me, in recent 4 or 5 years, I had some more practice in the local. Yeah, so, but generally speaking, for most doctors and nurses in the local, they are very nice and very professional, and really appreciate their great work. Thank you.
Thank you. Stretch, lay it on me.
I'm here. Stretching the CAC implement. Well,
Hold that mic up close so I can hear you.
all right.
Okay, not quite that close.
My little question is basically for Doc Mullins, seems he's the chief executive. How do you go about changing the law of OSP laws? Seems I've been fighting the devil, and my little problem is you can go to Advantage Dental, and if you're not an OHP member, it costs you $700 for uppers and $700 for lowers. But you go to, since you're on OHP, you go to Advantage Dental, you're on OHP, it's going to cost you $700 for uppers and $700 for lowers. How do you change this law so everybody can do it? Because I haven't been able to get teeth for 35 years, and it seems you got to be the doc has to be a patient for at least 2 years. Your tooth has to come out within 6 months. Then Advantage Dental will cover it. Give you dentures, and OHP will cover it. But seems this happened 35 years ago. How do you change the law? The lawmakers made it sometime somewhere. Now you got to change the law. So who's going to change the law if somebody doesn't speak up and say, "Hey, change the law"?
Okay, so Stretch, let's talk dental. So I know part of the challenge and one of the issues is around the benefit and what's covered under the Oregon Health Plan. And nobody in this room can impact the specifics of what's covered under the Oregon Health Plan. Would you like to speak from the dental perspective on answering the question on the benefit? Okay.
Sorry. I'll speak to that just a little bit. So I'm with Advantage Dental, and I've heard your concerns before, and I definitely appreciate you sharing them. So as a dental care organization, we don't create the Medicaid benefit. So that's across. That's from the Oregon. That's from OHA. It's not, or the Oregon Health Plan. That's not Advantage or Willamette or whatever the dental plan you're on. That's a Medicaid package. But I think in July, so it's still kind of being figured out. But there are some changes to the denture benefit, and so there will be some changes coming later this year. And hopefully we can continue a dialogue and we can help you out a little bit more.
So I think what she's saying is that there has actually been quite a bit of movement more recently than there has been in years around the dental benefit. And so I think from a legislative perspective and the benefit package, we're making some progress, but we do understand your frustration. And thank you for sharing it. Okay.
My name's Jim Templeton. I'm with the South Bend County Gleaners, and I've been injured on a job, not here in this location. I was in another location. Okay, I've been looking for a doctor. Okay, because you have your workman's comp. Okay, this is kind of ridiculous when you go in and you got a book about 4 foot thick, you know, and you go to these doctors and they say, well, we can't take you. We're not no more that situation. So what can we do about setting it up where us guys that has injuries can see a doctor? They said, I've got paperwork. I took it to one doctor and he said it'll be 6 months to a year before he even look at me. So I'm just saying, what can I do? The only way I can do it is walk into a clinic or I walk into the hospital with my injuries. Why should I do this? Why can't we have doctors available? Is what I'm trying to figure out. Okay, I'm kind of between a rock and a hard spot, you know. I got hurt on a job. I should be able to go to a doctor to get medical attention. But I've never seen this happen yet. So I'd like to see what we can do about that.
So if you want afterwards, I'll get your information and we'll see what we can do about connecting you up from a community perspective to figure out whether it's an OHP issue or a workers' comp issue and what we can do to help you. Okay? Thank you. What else? One of my cards was Stretch's question, so I think we got that one. Another one was a question for Benton County Health Department on in talking when Commissioner Dixon talked about the education and enhancing that. Are there some specific things that the county is thinking about doing around education or enhancing health? Was a question that came, and I'm not sure if Commissioner Dixon or Mitch can answer that.
I don't know if I can say anything specific, but we're always doing stuff around education and trying to promote the health in the community. A lot of our work recently is, I think, less about what you would have seen in the past where there's a health education class or something specific like that, and much more focused on policy issues in our community about how to build a healthy community. So our department's really actively engaging folks and engaged with our Parks Department, our Public Works, the Transportation Department, all of that, trying to look at ways to how do we design this community so it's healthy? Are there safe routes for kids to walk to school? Do we have a community that further promotes bicycle riding, makes it easy for people to get out and do exercise and those kind of things? Really trying to look at moving way upstream and saying we don't want to address health issues at the critical end. We want to prevent those at the upfront end and everything that we can do. And that gets into a whole lot of issues. You'll hear people talk about the social determinants of health and what are the things that what are the cards that you've been dealt in your life that make it easier or harder on your physical health, your mental health. And those are things like poverty and housing and, you know, your family dynamics and all sorts of things like that. And so what we're working on is lots of ways through engagement at schools, through these design projects and things, to really raise the bar in terms of awareness of health and making it easier for people to make healthy choices out in the community. So that's really been our focus, instead of what used to be the kind of the old tradition of come to this class and learn about this.
All right, what else? What other questions are there? Yeah.
I have a question about communication. So I'm a therapist in private practice, and I see this in sort of two parts, is how I can get communication from IHN about changes, and also how I can be in touch with other providers. Particularly, I'm thinking pediatricians, because I work with children. It's oftentimes really difficult for me to reach a pediatrician. I can send a release of information, and then what tends to happen is I get a packet of information back instead of just a quick phone call of a question that needed to be answered, or of another circumstance where the client doesn't really want me to talk to the, it's like some sort of physician, but there's repeated urgent care visits, there's a huge list of medications, and I think some coordinated care would really help the situation, and I just don't know how to effectively do that. So it's two, like IHN communication and then provider communication.
So those are both great questions, and we're doing a lot right now around provider services and provider outreach and making sure that we connect better with our providers. That's actually one of the main focuses moving forward this year. So I'd want to get your information afterwards as well to make sure we can get you on that list for information from IHN to you. In terms of the coordinating and all the pieces around that, that's a lot of what the Delivery System Transformation Committee that Kim was speaking to earlier does, and I'd be happy to share with you information on that so that if there's ideas on how to do that. We're working right now that we have a technology that we're working on that would be able to allow that coordination happen from a technical perspective once it's all been said it's okay, and that's just getting rolled out. So I think there's a bunch of opportunities coming. But I think the 2 points that you make are very valid and something that we're continuing to work on, and not the first time that we've heard them. So I would definitely want to connect with you afterwards and make sure we can loop you in on those, improving those processes. So thank you. Sam?
Yes, this is a question I believed I asked about a year ago when this event happened in Benton County, roughly a year ago. And maybe we have a little bit more information or a little bit more understanding at this point in time. But when the Affordable Care Act was initially implemented back in 2 years ago, in the start of 2014, the plan was for the federal government to cover a great big portion of the costs of Medicaid expansion, and here in Oregon, the Oregon Health Plan expansion, for a 3-year window. We're now a little over the 2-year mark into that 3-year window. And I don't know that we've been hearing much about the specifics or the details of how that funding stream from the federal government is going to be changing in a little less than a year from now, and what kind of financial burden is going to be transferred to the states to start picking up some of those costs. I mean, it's been incredibly successful to provide access to health insurance and to medical care to millions of Americans, and even in our state here. Now, what are the numbers? Didn't enrollment in the Oregon Health Plan go up by roughly 50% within the first year? Yeah, the first 6 months, to the point where we've got over 1 million people on the Oregon Health Plan in the state of Oregon. So about 25% of our population is on the Oregon Health Plan right now. And I think the uninsured rate is down to about 10% at this point.
I think it's actually 5.
5. So it's been hugely successful in that regard. Those numbers do directly affect the question that you asked over there, sir, because with so many more people having access to health care now, we're coming to realize we don't have enough providers to handle all the people that would like to be seen by doctors at this point. That's one of the reasons why we have a new medical school over in Lebanon that's trying to produce some new doctors that are hopefully making a commitment to serve in rural areas as well. But I'm just wondering if we have any clearer picture about what's going to happen roughly a year from now when that kind of 100% funding commitment from the federal government is going to start being decreased incrementally, and how's the state of Oregon preparing to deal with that transition?
So, Bill, would you be willing to give a thought on what's happening from the Oregon Health Authority's perspective as it relates to that? Would be great. So, Bill is our innovator agent, and he works for the state of Oregon.
Good. I'm going to put a tough question in now.
Okay.
So I work for the Oregon Health Authority, and we have been working on a plan and communicating with the legislature for this last year or two, and letting them know as the transition from 100% federal reimbursement to a lower and lower percentage, and it doesn't go from 100% to 60% the first year for the ACA population. It's really a slow, gradual, but there is a cost to all the states for that part of the general fund as it goes from 100% reimbursement. So we've been working with the legislature about what that gap is, about what the new general fund expenditures will be. We are actively working with the federal Medicaid agency, who really invests a lot of money in Oregon, and working on the renewal process to renew the waiver that allows us to do this coordinated care model and the great work that IHN CCO is doing. So we're actively working on that. We intend on having that application in May, and working with the federal government to continue the great coordinated care model work that's going on in Oregon. But it is a known number, Sam. I don't have it off the top of my head. The legislature is well aware of the budget gap that it's going to create, and actively working on a plan for it. So, thanks.
Thank you. What else?
I'll give you an easy one, Kelly. So, our Community Health Improvement Plan, the CHIP, recently we added housing as a social determinant of health as a goal for our community health plan. And having attended the meeting the other night among the men's shelter and community outreach, and the organizations that are talking about the new shelter, I'm just wondering, as far as goals or pilot projects, or how you see IHN contributing to that housing effort. I know that there's organizations that specifically do that, but how do you see the CHIP for IHN working into the housing efforts to reduce homelessness in the area?
So that's a great question, and what she's referring to is that the Community Health Improvement Plan for the IHN CCO was just updated, slightly modified and updated to have some more specific outcomes and indicators it's looking for. And I would say that the role that the CCO is playing in terms of that housing and homelessness piece is that convener piece that you heard earlier, that you heard us speak about. We supported and helped put together a forum at the end of January, really trying to bring out all the opportunities and the pieces and bring the people together. So the CCO is in our scope is not to build housing. That's not in our scope. That's not in our contract, of course, with the state. Our goal is to really bring all the people together and the players together and connect all the dots and be the convener so that the right people can talk to the right people to figure out how we start to work to address this. Certainly recognizing as it impacts our members, the members that we serve, which some are clearly impacted, how do we fit in and how do we help them and help them coordinate their care and coordinate what's happening in their lives. Certainly having stable housing is an important piece of that, and making sure we connect them with the resources that can help them do that. But we really see our role as a convener and bringing together all of the players, and do take that seriously and are constantly working on it as we speak. So it is an important piece, and one that we're very supportive of. Again, as bringing together the convener and bringing the right people together, because it's not necessarily in our scope to build housing or do that kind of thing, but to be that convener, to coordinate it. That answer your question?
Yeah, I just wanted to bring up some pilot project to help connect members, OHP members, to housing resources, such as they are.
I'm going to defer to Kim, who chairs that committee.
We actually have a couple of pilots. We have a couple of traditional health worker pilots where you have navigators who are help connecting members to resources. So that would be one. We have a youth shelter, a youth emergency shelter pilot, where we are working with youth in an emergency shelter on their healthcare needs and, of course, long-term sustainable. They're helping them with all their needs. Housing would be one of them. And then we have a pilot with Jenna, where'd you go? Willamette Neighborhood Housing to do, where we have the pilot covers a navigator in the housing units themselves. So as Kelly said, you know, housing is an integral foundational piece of somebody's social determinants of health, right? Along with food insecurity, along with their environment. So as a CCO, we have to take all those into consideration and focus our efforts on what's going to improve somebody's health with the tools that the CCO has. And we're counting on the community, our community partners, to add into that the tools and skills that they have in their particular area. So in the pilot with Willamette Housing, what they're bringing is the housing. What we're bringing is the health, right? The health and the connections and that collaboration of individuals who can then wrap ourselves around these issues and concerns of each of our population and improve their health outcome. As part of that population health definition is looking at everybody's situation and all the needs that they have in their because of who they are and what they've been through and what's happened to them, and how we as a community can help guide them through the resources we have to get that better outcome. And so yes, we are doing a lot in that area.
So to follow up on that and all the other discussion of pilots earlier, what is sort of the time frame for a pilot to reach a success or not success decision, and then what happens next, and what's the time frame happening next in terms of propagating those pilots? Because you've talked about pilots,
Yep.
not widespread programs of new stuff so far.
Yep, and we have a whole outline process for that.
So as the IHN CCO, we are an organization, right? We're an incorporated entity, and as such, we have specific financial processes we have to follow. We're not a foundation, we're not an institute, right? So we have a year that we have to spend some dollars before we have to close out our books at the end of the year. So the process goes, within a certain year, we will review pilots and award funds. Then those dollars have to be spent in that pilot the next year. So we can't do 2 or 3 or 4 year things because the way that our financials are processed won't allow that. So also within our pilot structure, we've developed some criteria. And one of those criteria is sustainability. When we first went out and talked to community stakeholders about things that they thought would improve the health outcomes of our individuals, we heard over and over again, oh, there was this great project 8 years ago. It had really great outcomes. Well, what happened to it? Oh, the funding ended. Oh, there was this really great thing we did 3 years ago in the schools in Alsea. Well, what happened to it? Well, the funding stopped. So it was very important to us when we started that sustainability be built into these pilots from day one. And right now we are struggling as a DST, and part of the reason we're having the TA person come in is because we have a lot of pilots that are doing really good, and they're at that point where they're not quite sustainable. And so what do we do? And so we're trying to figure that out as a DST. I don't have a really good answer for you, but we've brought in some professionals and we're hoping for some really good guidance.
Good questions. Yep.
What programs or pilots focus on elders that do you have?
I'm not sure that we have a specific amount, but we do have all of the pilots are on our website, and a description of every single one of them is available, and I can certainly send you the link if that would be helpful, but I don't know if we have any specific ones off the top of our head. It doesn't sound like we have some specific ones related to that, but that's certainly something that you know, if it meets all the elements, absolutely, that we would be happy to consider. Yeah.
Hi, I work for a company that does mental health care in 5 different counties. And my questions are basically around that. All of the counties, since they have different health organizations, tend to manage things in a different way. I was wondering first if there was any thoughts that the CCO in this county might be expanding to other counties, or is it just going to be staying at the 3?
Right, so our service area is Lynn, Benton, and Lincoln counties right now, and that's just the service area we serve for now.
Okay, but there haven't been any like definite goals for expansion or anything like that at this point?
Not right now.
Okay, my other question is regarding the payment structures in the counties that don't use a CCO. Then we would just contact the county's mental health division, put our paperwork together, send it off to the state for payments. In the counties with a CCO, we send it to the CCO and then never really hear whether it's been approved, where it's at in the process. I was wondering if there's anything we can do to kind of initiate that communication and try to make sure that that's still working to where when we're sending in our next one, we know whether or not the last one has been approved.
So are you talking about contracting?
Yes.
Okay, so if you're having, if IHN CCO in our counties is not responding well to you, I need to see you afterwards as well. So we can make sure we work on our communication.
Okay, thank you.
Okay, thank you. Any more questions? Okay, well, if you wanted to ask a question and didn't, please feel free to fill out a yellow card and we will follow up with you on that. If I said I wanted to see you, I will try and remember everybody, but please make sure you come up so I can get your information so we can follow up. So thank you very much for everybody's feedback tonight. Appreciate it.